Now I invite Dr. Navina Rajendran, paper FP1100 for her presentation.
Good morning everyone. I am going to present the visual outcomes in a case series of primary piggyback IOL in non-ophthalmic cataractous eyes. Non-ophthalmos is a condition with a short anterior and posterior segment and increased lens to eye volume ratio. Cataract surgery in non-ophthalmic eyes poses problems in terms of IOL power, non-availability of a single high-power IOL which is out of range or near the upper limit of power inventories to achieve emetropia. To overcome this problem, the concept of piggyback IOL, that is implanting two IOLs back-to-back, was first described by Gayton in 1993. Our study included 7 eyes of 6 patients with non-ophthalmos whose mean axial length was 16.12 mm and the required mean IOL power was plus 56.5 diopter. Preoperative workup included detailed anterior and posterior segment evaluation with an emphasis on IOP, anterior chamber depth, and endothelial cell count. One patient had advanced glaucoma at the time of presentation and another patient had undergone vortex vein decompression for uveal effusion prior to surgery. Optical biometry with IOL Master 700 was done and the axial length was cross-verified using B-scan and Hoffer-Q formula was used for IOL power calculation. Coming to the surgical procedure, a prophylactic YAG-PI was done for all patients. Intravenous mannitol 100 ml was given half an hour prior to surgery. Subtenance with facial block was given to avoid positive pressure due to lid squeezing during surgery. A standard phacoemulsification procedure with implantation of a foldable hydrophobic single-piece IOL in the bag, followed by implantation of a foldable hydrophobic 3-piece acrylic IOL in the sulcus was done for all patients. There were no intraoperative or perioperative complications like uveal effusion, suprachoroidal hemorrhage, or aqueous misdirection syndrome. 2 patients developed significant anterior chamber reaction with fibrin membrane on postoperative day 1, which was treated conservatively with topical steroids and intramuscular injection dexamethasone. The spherical equivalent reduced from a mean plus 9.75 diopter preoperatively to plus 0.75 diopter postoperatively. Mild interlenticular opacification was noted in 2 eyes. One patient had widespread pigment deposits over IOL with optic capture and tilt of the sulcus placed IOL. No major postoperative complications like significant interlenticular opacification, PCO, or secondary pigmentary glaucoma occurred during the mean follow-up period of 2 years. This is a table showing the preoperative and postoperative data. You can see that the minimum IOL power we placed was 47 diopter and the maximum IOL power placed was 63.5 diopter. We did not reduce the power for sulcus implantation as we aimed to leave the patient slightly myopic after surgery. Even then, in the postoperative refractive correction, you can see that we landed up in a mild hyperopic spherical equivalent after surgery in 3 patients. Visual acuity improved in 5 eyes, remained unchanged in 2 eyes, and the visual acuity was poor in 1 eye, which was 5/60 because of glaucomatous optic nerve damage. Ultrasound biomicroscopy was done for all patients, which showed well-centered piggyback IOL with 1 in the capsular bag and 1 in the ciliary sulcus in 6 eyes, except in 1 eye, which is shown in figure E, which had an optic capture and tilt of the sulcus placed IOL. Mild interlenticular opacification in the form of Elshing pearls nasally was noted in 1 eye in figure B. Figure D showed a mild thin thread-like nasal ILO. In figure B, C, and E, you can see precipitate-like deposits, discrete clumps close to each other, occupying a small area in the central interface, similar to those described by Eleftherides et al. All these ILOs did not cause any visual disturbance. Discussion. Another option in non-ophthalmic patients is to place a customized high-power IOL. An IOL with a power of greater than plus 40 diopter would have very steep radii and would behave more like a sphere, inducing increased spherical aberration, reduced modulation transfer, and compromised resolution. Piggyback optical systems induce less spherical aberration and provide superior image quality when the optical centers of the 2 IOLs are aligned than a single high-power IOL of the same power. And eyes with multiple acrylic implants demonstrated a substantially greater depth of field compared with eyes with single acrylic implants. We decided to place a 3-piece IOL in the ciliary sulcus to prevent inflammation and iritis caused by a single-piece IOL in sulcus. And we did not notice significant ILO in any of our patients, probably due to the space created between the two IOLs by sulcus implantation. In conclusion, implanting two piggyback IOLs, one in the capsular bag and one in the ciliary sulcus, gave good results in eyes with an extremely short axial length, no significant interlenticular opacification, posterior capsule opacification or secondary pigmentary glaucoma occurred up to a mean follow-up period of 2 years. However, using IOL Master 700 and Hoffa-Q formula underestimated the required lens power, resulting in a mild hyperopic refractive error after surgery. These are my references, and thank you for the opportunity.
Excellent presentation. But I was wondering, why did you not put a single IOL of the power which was required? Because now the Indian companies are giving the full complete power IOL 55, 60, whatever you want,
Yes, sir.
of a particular size. Like if you have a nano ophthalmic eye, then even the smaller lens and all these things, you can ask them to make accordingly.
Yes, sir.
Of your choice.
When we did a literature search, we found that piggyback optical systems gave a better visual acuity for the patient. That's what I
See, if
included
you
in this.
another
Yes.
question is how to calculate a piggyback power of the piggyback IOL.
Yes, sir.
Because if there is a residual power of 5 to 6 diopters, the piggyback IOL required is of plus 10 diopters.
Yes.
It's a much higher than what you actually calculate on refraction or whatever. So you are putting overall thickness of the two lenses is much more than the single lens, and also you are putting single lens in the bag compared to one in the bag and the sulcus. So I feel that with the current scenario where your IOL power and the size can be met with by the customized lenses, customized IOLs which are available, that's a better option, I believe.
Okay, sir.
Anyway,
Thank you.
nice presentation, but keep this in mind next time.
Yes, sir. Thank you.